Occupational English Test. Listening Test. This test has two parts. Part A. In this part of the test, you will hear a midwife interviewing Jenny, a woman who is pregnant. You will hear the consultation once only in sections. As you listen, you must make notes about the consultation under the headings given on the answer paper. Turn over now and look quickly through Part A. You have 1 minute to do this. You must give as much relevant information as you can under each of the headings provided. You may write as you listen, and there will be pauses during the consultation for you to complete your notes under the relevant heading and to read the following heading. There will also be 2 minutes at the end of the test for you to check your answers. Give your answers in note form. Don't waste time writing full sentences. Remember, you will hear the consultation once only, and you should write as you listen. Now read question 1. Question 1 has been done for you.
Hi, Jenny.
Hi, Sue, how are you?
Good. Congratulations.
Thank you.
On your pregnancy.
Thank you.
Now, I'm one of the midwives in the antenatal clinic, so you'll probably be seeing quite a bit of me during your pregnancy.
Mm-hmm.
You'll see a few midwives through the clinics, but we all work down here, so you'll see a few of us.
Do I see
along
you
the way.
each time, or does it?
Not each time, but
Right.
just probably, a few here and there. Just
Okay.
depends what days we're on and when you come in for your visits.
Yep.
So we just, with the first visit, this is the booking visit, so we just go through a variety of things, just looking at your medical history and talk about some things in pregnancy, and then if you've got any questions along the way. So
Yep. I've got a list ready.
I've got a list, great, okay.
Now look at question 2. You will hear a discussion about Jenny's medical history. First, take notes on Jenny's gynecological history.
Now, this is your first pregnancy?
Yeah.
Okay. And you've had no other pregnancies before then?
No.
Okay. Now, just with your due date and things, I just want to find out when was your last first day of your last period?
Was about January the 26th.
Okay. And do you have a regular cycle or irregular cycle?
Yeah, no, it's regular.
It's regular. How many days?
28 days.
Okay, that's fine. So we'll work that out for you and give you the exact date. You had an ultrasound at
I had
8 weeks?
Yeah.
Okay, so we'll get the results of that, and that'll give us also an accurate date for you
For the due date
as
yep.
well.
Although it's how often is it on the due date?
Never.
Never. Okay.
No, not never,
So
but your due date's actually a month, so it's anywhere from 37 to 42 weeks, so it's the due date is really definitely
So kind
an
of
estimate.
2 weeks either side.
2 weeks
of the
either
due
side
date.
of your due
Okay.
date. And any problems falling pregnant? You had no fertility problems?
I'd been on the pill for like 15 years or something, and we thought it would take a long time, perhaps when I went off it. But
Sure.
yeah, first
Okay.
month.
Yeah, okay, that's fine.
Now, take notes on Jenny's family and surgical history.
We have to ask this question. You're not related to your husband?
No.
No? Okay. No family history of any hypertension or diabetes or cardiac problems? No? Okay. And no other surgery? No, you have ever had a general anaesthetic or anything in the
I had my
past?
tonsils out
Tonsils out.
when I was about 20, and I was fine.
And no problems with the general anaesthetic?
No.
Okay, that's fine.
Now, look at question 3. You will hear a discussion about Jenny's osteoporosis. First, take notes on the specialist's view.
The only thing I wanted to mention is that I have osteoporosis.
Okay.
And so I wanted to talk about that a little bit because I have a specialist I see for it, and we've discussed pregnancy, and he says that he doesn't think being pregnant itself is an issue for the body because you take calcium supplements, but it doesn't take calcium directly from your bones.
Okay.
But he suggested thinking about whether to breastfeed or not because breastfeeding takes calcium directly from the bones, which
Sure.
may cause fractures. And he's dealt with 2 women who've had osteoporosis and been pregnant before. One was fine, and the other one had a lot of fractures even during the pregnancy. So
Now, take notes on the patient's view.
I feel really bad about not deciding whether to breastfeed or not because there's a lot of pressure.
Yeah.
People, all the magazines and everything have.
Yeah.
It's best to breastfeed. Your baby will have higher IQ if you breastfeed, all that kind of stuff.
Sure.
So
Now, take notes on the midwife's advice.
I think it's important though to also look at your health first. So as important as breastfeeding is, I think it's also important that you need to look after your health. So the formulas and things these days that babies have are very close to mother's milk anyway. So and I think it's probably best to go with what your physician says. So
Now look at question 4. Take notes on current and suggested supplements.
are you taking calcium supplements?
yeah, I take
moment.
vitamin D and calcium
Okay.
at the moment.
So it's a good idea to keep that going through the pregnancy.
Yeah.
And then afterwards as well, when you're not feeding as well, it's probably a good idea just initially in those first sort of few weeks after the birth.
Yeah.
If you wanted to breastfeed, if you felt that perhaps you might change your mind, then maybe you could discuss that with your physician as well, but maintaining that you keep up those calcium supplements and vitamin D.
Yeah, I guess I'll see how I go during the pregnancy and if any problems arise.
Sure.
And make a decision at the end.
Yep.
Yeah.
Okay. And you don't take anything else for that osteoporosis?
No.
No other? Okay.
No.
And are you on any other medications or anything at the moment?
I've been taking folate.
Okay.
I started taking that when I started trying to get pregnant.
Yep.
So
Sure.
yeah.
Okay. Sometimes it's recommended to take a multivitamin of some description as well. It's handy during pregnancy, and also we keep an eye on your iron levels throughout your pregnancy. So often most women will drop their iron levels at some stage in their pregnancy, usually later. So it's we often give you some iron supplements to take as well. But some women like to also just take those sort of, I guess, as a prophylactic. So it can be something you can take along the way.
Now look at question 5. You will hear a discussion about Jenny's morning sickness. First, take notes on Jenny's issues.
And
you're generally well?
I've been having really bad morning sickness.
Okay.
Virtually from the day I got pregnant onwards. Although the doctor said it was usually, took a few weeks to kick in, but it kicked in straight away. And I've lost about 8 kilos to this point, and I'm concerned, one, about the weight loss and the health of the baby in particular.
Sure.
And how to keep managing it, because I basically haven't worked since I got pregnant.
Okay.
So,
so how many weeks are you at the moment?
12 weeks.
12 weeks.
Moment.
Okay, so that's a very normal thing to have that nausea, and you're vomiting with that as well, or just the nausea?
I just can't. I eat during the night to try and stop the nausea. I have crackers beside the bed, and I try and do that to stop myself vomiting when I wake up, but doesn't matter what I do. I wake up and I vomit, and the nausea lasts most of the day, but it's particularly bad. It seems to be particularly bad at night time.
Okay.
So when I lay down to sleep. So if I can get to sleep before 10 o'clock, I can sleep through it. But if I'm awake after that, then it's just horrible.
Right. So then that's at least you have that. You need to get to sleep earlier rather than later.
Doesn't work.
But it doesn't always work.
Now, take notes on the midwife's explanation and advice.
This is very normal to have that nausea and vomiting. Most women will get that from early on till around their second trimester, which is sort of 16 weeks. So up until then, you'll probably continue to have that nausea. Unfortunately, it's a hormone thing that you've got a lot more hormones and things flowing through your body. So one of them creates that nausea and vomiting. Some people like to think it's a good sign that placenta is actually attaching well to the wall of the uterus.
Yep.
But it doesn't always make you feel better to think you're going to be vomiting until that time.
Because everyone said 12 weeks it'll pass, but it hasn't passed. So I figured I'd better start thinking maybe 16 weeks.
Yeah, often it is more 16 weeks. So taking smaller meals if you can during the day more regularly.
Well, that's the thing. All I've been eating is rice and crackers, and I'm worried about...
Which is why you're losing your weight probably.
And just because I can't stand the smell or the taste of anything else. And I'm worried about the baby. Is it going to be all right if it just has crackers and rice?
The baby will always... your placenta will always nourish the baby and take what it needs for the baby from you, which is why you will lose the weight. So you don't have to worry that what you're eating doesn't necessarily mean the baby's only eating rice and crackers, because it'll always take those supplements from you. So it's probably, if you can manage to get a multivitamin things into your system, that would be good as well. And trying to keep your fluids up. If it got to a point where you lost too much weight and we were concerned that you weren't able to continue to keep your food down, they sometimes like to hospitalise you just to get you a drip and get that back.
Now look at question 6. Take notes on the midwife's advice about air travel.
I've got a conference coming up for work, so I have to go to fly up to Queensland for the conference. Is there any concern about or any sort of time when I should or shouldn't fly during the pregnancy?
Often we advise women not to travel in your first trimester just because of the amount of radiation on aeroplanes. After that, it's okay. A lot of women do need to fly for work, so we can't restrict that. And these days, aeroplanes are a lot safer with their radiation levels and things, but it's usually advised if you can avoid it to try and avoid that first trimester. So will that be in that first?
It'll be, it's meant to be in a couple of weeks.
Okay.
So it's just kind of the end of the first trimester.
Yeah. And I mean, it's not like you're flying every day, so just that one-off flight, I'm sure, that'll be fine.
Now look at question 7. Take notes on the information given to Jenny about prenatal tests.
Have you got any other questions there at all?
What sort of tests are done along the way?
Sure. Okay. Now there's quite an extensive amount of prenatal testing. All of it is of your own choice, so it's not compulsory testing. So it's really up to you to go home and discuss that with your husband and decide what you feel you would like to do. There are a number of tests offered around 11 weeks, an ultrasound and a blood test that test for Down syndrome, and they look at the folds on the back of the baby's neck on the ultrasound, and also there's a blood test that can indicate risks and give you then an idea of whether there is a risk there or not, and then you can go on to have further tests. If there was no risk, then there's no need for those further tests. There's other tests then where they are invasive, so they do, it's called an amniocentesis, where they would take a sample of the amniotic fluid that is around the baby, and that has some of the baby cells in it, so they can look at the genetic component of that and get a more accurate idea of if there was any problem with the baby. If any of that came to be, there's a lot of counselling and things that goes along with it as well, so you'd have other appointments with counsellors and things to discuss the implications of that and what you would like to do. So I think it's very important we give you some information today to take home with you to read about all those different tests, just to discuss with your husband, and maybe do some other reading around that to decide what you'd like to do. Yeah.
Now look at question 8. Take notes on low blood pressure.
I have sometimes I have low blood pressure, and this is like, I know it's like way down the track, but I've heard that if you have low blood pressure, they're reluctant to give you an epidural. Not that I think I'm going to go straight for it, but is there any truth about that?
No, anaesthetists are very pretty good at all the things they do with their epidurals. They come across women with the low blood pressure and high blood pressure, and they have different things they can do to counteract that. Sometimes having an epidural can just drop your blood pressure initially because of the amount of drugs they give you, but they often give you a fluid load and things beforehand, so they give you a good litre of fluid through a drip that can help to just raise that blood pressure slightly, so that to counteract that drop in blood pressure. But I wouldn't be worried about that. A lot of women have nice low blood pressure throughout their pregnancy, and it doesn't impact on their epidural.
During having low blood pressure during the pregnancy is not a problem either?
No,
yep.
Not at all.
Okay.
You do get a lot of changes in your body when you first get pregnant, and you have a much larger blood volume that is created that's pumping through your body. So often in that first trimester, women do feel have periods where they might feel a little bit dizzy and faint, and their blood pressure, and when their blood pressure is dropping, just their body's getting used to that extra volume of blood that the heart has to pump around. That's quite normal. But yeah, you eventually your body balances that out, and that's fine. So yeah, it's nothing to be concerned about.
Okay.
Now look at question 9. You will hear a discussion about pathology tests. First, take notes on Jenny's recent results.
Now, you would have had some bloods done with your GP. Have you got those results there?
Yep.
Okay, now just have to have a look at those. Now, your haemoglobin, it's about 130, so that's very normal at this stage, and that, as I said before, will tend to drop a little later.
Is that
in your
what
pregnancy.
measures your iron?
Yes.
Right.
Yep. There's also we can do iron stores and things as well if we were worried that your haemoglobin was dropping, and your everything else looks fine. Yep.
Now, take notes on future tests.
There's a couple of other tests where we talk about those in subsequent antenatal visits that happen later on in the pregnancy. We also do some more blood tests and check your iron again at around 28 weeks. Okay, when was the last time you had a pap smear?
Within the last 2 years.
Okay, that's fine. So usually we just recommend you have another one 6 weeks after the baby's born when you have a checkup.
Yep.
Now look at question 10. Take notes on future plans.
Okay, so we'll make an appointment for you to come back and see us when you're 18 weeks, and that usually corresponds with your 18-week ultrasound as well.
So how often do I see you come in for the visits?
Initially, it's only once a month for the first trimester and second trimester, and then at 28 weeks it's every 2 weeks, and then from 36 weeks it's every week. So yeah.
And if I have any concerns along the way, can I call the hospital here and speak to one of the midwives?
Yep, absolutely. There's an emergency department that you can come through any time of the day or night, and if there was any problems at all, and they'll see you down there and refer you wherever you need to go. So yep, that's fine.
All right.
So I'll give you all those numbers and things before you leave. And
so I have the
information.
ultrasound done before I come and see you?
Yeah, we'll make an appointment for you before you leave today. Okay.
All right. Thanks for your help.
No problem.
See you.
That is the end of part A. Part B. In this part of the test, you will hear a talk on malaria. You will hear the talk once only in sections. As you listen, you must answer the questions in the spaces provided on the answer paper. Turn over now and look quickly through Part B. You have 1 minute to do this. You may write as you listen, and there will be pauses during the talk for you to complete your answers and to read the following question. Remember, you will hear the tape once only, and you should write as you listen. Now read question 1. Question 1 has been done for you.
Good afternoon. Today I would like to talk to you on the topic of malaria. This is a major disease affecting hundreds of millions of people throughout the world. I'd like to tell you a little bit about the history of the disease and our attempts to control the disease, then explain the reasons why malaria has come back,
Now read question 2. Now listen and answer question 2.
Malaria has been with us for many thousands and thousands of years. The disease is found predominantly in the tropics because that's where the appropriate mosquitoes are found that transmit this disease. Female mosquitoes must take a blood meal before laying eggs, and this drives them to find a host where they can take up blood. At the time they take up blood, parasites in the mosquito are injected into the circulation of the host and later give rise to the disease. The parasites travel in the blood first to the liver, where they don't cause any symptoms at all but undergo a period of maturation there. After a variable period, probably 7 days but can be as long as several weeks, the parasites emerge into the bloodstream where they cause disease in people who are not immune to malaria.
Now read question 3. Now listen and answer question 3.
The symptoms can be quite non-specific at first, with fever, sweats, chills and rigors, but the disease can also have manifestations causing shortness of breath, severe anemia with low blood counts, and sometimes proceed to the serious complication of cerebral malaria. There are actually 4 major species of malaria that infect humans, but today I will concentrate on the most serious one, Plasmodium falciparum malaria. That's the malaria that is responsible for cerebral malaria that leads to so many deaths in young children, but is also a major problem for women during pregnancy.
Now read question 4. Now listen and answer question 4.
Towards the end of the 19th century, the life cycle of malaria was discovered. In other words, it was recognised that the mosquito carries the parasite to susceptible hosts who become very unwell. It was also recognised that only some species of malaria transmit the disease. Having discovered that mosquitoes transmit the disease, Ronald Ross, who first discovered the life cycle, immediately recognised a method for controlling the disease. For example, removing the breeding sites for mosquitoes, or putting people in screened areas at night. That's the time when the mosquitoes would normally bite, so to protect them from bites, or alternatively to use insecticides to destroy the larvae of developing mosquitoes, or alternatively to spray houses with agents such as DDT. These agents are successful because most mosquitoes bite inside, then go to rest on the walls nearest to where they've bitten. If DDT is coating the walls, the mosquitoes are then poisoned by the DDT, thus blocking the life cycle and preventing transmission to other people.
Now read question 5. Now listen and answer question 5.
Mosquito control measures such as with the use of DDT were very successful in many countries. Particular examples that show the technique to be successful were found in India and Sri Lanka, such to the extent that in the early 50s the belief was that there could be a malaria eradication campaign to eradicate malaria from the world. Unfortunately, however, this didn't take account of the different behaviour of mosquitoes in different parts of the world. So mosquitoes that exist in forests and bite during the day, or where people don't live in adequate housing, this strategy would never have worked. However, when the DDT spray campaign started in India and Sri Lanka, there were major successes, such that, for example, in Sri Lanka in the mid-60s, all spraying was stopped. The view was that malaria had been solved. Within 5 years, however, malaria had returned, and from a very few cases, there were more than 500,000 cases in a year. Similarly, India had successes in reducing the caseload from 75 million in the 1950 to only 70,000 in 1960.
Now read question 6. Now listen and answer question 6.
We could perhaps move to think about other possible ways that we might control malaria, and I'll start by a little background on developing immunity to malaria. More than 100 years ago, Robert Koch, who was famous for his work on tuberculosis, looked at malaria in Papua New Guinea. He noted that in that area, where there was a lot of malaria, it was very common to find parasites in the blood of young children. They became less common in children, let's say, around the age of 5. By teenage, however, parasites were relatively uncommon, and clinical episodes of malaria were quite rare. However, we know that if you go to look in the blood of asymptomatic adults, it's very common to find parasites. In other words, this is a very good example of a happy coexistence between the parasite and the host. So this is asymptomatic malaria in a person who is semi-immune to the disease. It's also referred to as concomitant immunity, or immunity in the presence of ongoing infection. Such a condition occurs in many parasitic diseases, but would not occur in a non-immune person. These observations that Koch made were validated by others, and also gave him the idea that if everyone in the population could be treated with drugs, both people who were sick, but importantly also people who were well but could be carrying parasites, could also lead to control of the disease.
Now read question 7. Now listen and answer question 7.
This strategy, of course, can be partially successful. However, what Koch didn't know at the time was that, first of all, they could be resistant to the drugs, but also the drugs may not be effective against the sexual forms of the parasite. These are the forms that the mosquito takes up and allows them to develop in the mosquito, later to infect another person. So once again, it was an example where we had limited knowledge of the biology, hence the proposed strategy would not be successful in this case. Yet another problem for Koch would have been the fact that some parasites have the ability to rest in dormant stages in the liver for a long time, sometimes for years, for example, and in fact the drugs that are used to treat clinical malaria are not effective on parasites resting in the liver. Their resting or so-called sleeping forms is the hypnozoite, that exists in the liver for quite a long time.
Now read question 8. Now listen and answer question 8.
A recent innovation has been to use mosquito bed nets. These are nets that a person would put over them at night time to prevent bites from mosquitoes, but they're much more effective when they're impregnated with insecticides such as DDT. In certain controlled areas, this has been shown to be a very effective mechanism for reducing the morbidity and mortality from malaria. Observations from a biologist, however, would suspect that the mosquitoes may become resistant to DDT, or alternatively, mosquitoes may alter their behaviour such that the majority population may bite before people go to sleep under the nets at night.
Now read question 9. Now listen and answer question 9.
Another important aspect for malaria control relates to treatment with drugs. I've already referred to the ways in which drugs could theoretically be used to control malaria by treating all the population and thereby preventing transmission. But the main use for drugs is for people who are acutely ill with malaria. So a child or adult presenting with fever, sweating, headache, who has symptoms of malaria would be treated with one of several drugs. Unfortunately, the parasites themselves have become resistant to the cheap, freely available drugs, and in areas where there are no alternatives, we have seen an increase in illness and mortality from malaria. Newer drugs are more expensive, less well understood perhaps, and some of the side effects may not be well known.
Now read question 10. Now listen and answer question 10.
So at the moment, we could say there is a global crisis in malaria. At least 1 million people die each year, and at least 500 million are infected each year. 40% of the world's population live in countries that are at risk from malaria, with the greatest burden falling on children and pregnant women. And unfortunately, the situation is not improving.
Now read question 11. Now listen and answer question 11.
Of course, with all this concern about malaria, those of us in the research field are delighted with the interest of philanthropists such as Bill and Melinda Gates in supporting initiatives to develop a malaria vaccine. Large amounts of money have been invested for research, and many groups around the world are attempting to develop such a vaccine. There are three major fronts to the attack with vaccine. One would be to make a vaccine against the form in the mosquito. Therefore, an individual who is challenged by a mosquito theoretically would never become infected. A second vaccine would be a vaccine against the blood stages of the parasite. This would not stop the individual being infected, but would reduce the symptoms of the disease. A third type of vaccine would be a vaccine against the sexual forms, so that when an individual is bitten by the mosquito also takes up the serum with antibodies. That means that the mosquito cannot transmit the infection. I think what one has learned from history is there's not going to be a single one-shot solution to malaria, but what we must do is apply what we know with whatever technologies we have to reduce the impact of this terrible disease, and in the hope that we control and reduce the number of deaths and at the same time reduce the serious morbidity from it.
That is the end of Part B. You now have 2 minutes to check your answers. That is the end of the listening